Hello everybody, you're all refreshed after your coffee break. I'm just going to put on my timer here so you're not late for lunch going forward as well. Thank you so much for having me today. Thank you, Sarah, for the very kind invite. It's a real privilege to be here today. I'm super nervous. A bit like a very famous public figure, I've been out of circulation for the past 4 months. This is my first public appearance. Unlike her, who hopefully has a lovely professional supportive team behind her preparing her for a re-emergence, I had a phone call with my Irish mammy last night who said, so long as you don't talk like an idiot and don't turn up looking like a sack of potatoes, you'll be fine. So the bar is set pretty low today, I'm afraid. So I'm a neuropsychiatrist, one of those, and I work up in Preston in the forensic population. And today, Sarah's asked me to talk a little bit about brain injury, suicide and self-harm. So this is a serious topic, and because of how common depression and self-harm and suicide is, you may have been touched by this, or a close member or loved one in your family may have been touched by this. So if you need to take a moment, that's chill, okay? Be kind to yourself and talk as well. Talk about it at the break or afterwards whenever you're at home, okay? So usually whenever I'm giving a talk like this, I have to spend the first 20 minutes describing to psychiatrists or mental health professionals about how important brain injury is, and how common it is, and how the psychological impact of brain injury often is greater than the physical impact of brain injury. But I'm teaching my granny to suck eggs with this population here. You all know that brain injury is common. You also know that TBI stands for traumatic brain injury, because I've had to explain that more times than I care to remember. And we also know that all mental disorders are more common following a brain injury. So that includes anxiety, PTSD, post-traumatic stress disorder, psychosis, sleep disorders, and biggest of all is depression. So just a wee bit about depression. I have to put on my granny reading glasses now. Depression is super common. About 15% of the adult population in the developed world suffer from depression, and we know it's a leading cause of global disability. Depression is lifelong, and we know that children can suffer from depression, as can the elderly, but there are particular peaks in life around about the 20 to 30s age and between the 50s and 60s. It's characterised by that absence of affect. So it's not just that feeling of low mood, it's that inability to enjoy things that would have ordinarily given us pleasure across a broad spectrum of things. And it typically will have psychological symptoms, biological symptoms, and then the social impact as well. And to have a diagnosis of depression, those symptoms have to be there of varying severities for approximately 2 weeks and present almost all of the time. And it can be classified as mild, moderate, or severe depending on the severity and the impact and whether or not there are suicidal ideations or intent. It can also present in an atypical way, and it can present with psychosis. So people who have delusions, they're usually paranoid or persecutory delusions, delusions of being worthless or nothing, hallucinations, often about death or dying or destruction, end of times, and there can be sort of altered thinking as well. It is very different from dysthymia. So dysthymia is a chronic lower level of having low mood, usually lasts for a couple of years, even longer than that. So people who are just chronically feeling sad and down in mood. And adjustment reactions. So you may have seen the Barbie movie. And they described depressed Barbie, didn't they? She wasn't depressed Barbie, she had an adjustment reaction, yeah? So I should write to them, shouldn't I? It doesn't sort of quite slip off the tongue the same way, though, adjustment reaction Barbie. So Barbie was reacting to the patriarchy, wasn't she, being established in her world. An adjustment reaction can happen after a major life event. So loss of a job, change in role, loss of a loved one with grief. And usually you can sort of identify what the trigger has been, and recovery happens over a period of time. Sometimes adjustment reaction can then lead on to depressive illness. Interesting though, Barbie was cured completely whenever the patriarchy was destroyed. So these are kind of the outline of the different symptoms you get with depression. And busy slide, probably not very legible from where you're sitting, but if you'd read down this, you'll see sort of the overlap of some of the things that we commonly see following brain injury as well, in particular executive functioning symptoms or executive dysfunction. So let's move on to talking about depression and brain injury. Well, if depression is common in the general population, it's even more common following a brain injury. So studies showing that within the first 10 weeks post-brain injury, about 56% of people could have a diagnosis of depression. And the first year, 57% could be diagnosed with a major depressive disorder. So that's that moderate or severe depression following a moderate to severe traumatic brain injury. And they're staggering figures, really, whenever you think about it. And then that kind of leads you to think, well, we're clearly underdiagnosing depression in this population. And even as a neuropsychiatrist, I'm underdiagnosing depression in this population. And that's often because of these issues that we'll talk about in a minute, and in particular, this atypical presentation. So often our patients won't present with, I feel down, I feel low, but it'll be a change in function. It might be an increase in irritability, aggression, or agitation. It might be cognitive impairment that's out of keeping with what their brain scans are saying or what you would expect for that brain injury. It might be disengagement from therapy. Yeah, the patients who aren't turning up to their appointments, who are maybe been turning up for their appointments, half-heartedly going away, not doing the practice or the things in between the sessions. And we also know that there are barriers to accessing mental health if you have any neurological condition, and in particular brain injury as well. And this is something with my faculty that we've been trying to combat for many years now, and will continue to do so. And we're so pleased. I came in for the second bit of the MND presentation talking about the importance of mental health and of psychological support for people who have neurological conditions. Please keep flying the flag, because it is a wee bit of an uphill battle at times. We know that people aren't even asked about their mood or depression. And I think the Neurological Alliance did their survey, and about 60% of people hadn't been asked about their mood within the first 3 years following a brain injury. And given how prevalent it is, you know, if your take-home message from today is ask, please just ask. There is a lack of special services, so people who have more complex mental health needs, there's often a closed door. And a lot of my colleagues come across will say, oh, but that's brain injury, that's nothing to do with psychiatry. Well, I don't know how you uncouple the brain and the mind. Please show me how that happens. Every psychiatrist, every mental health professional can treat depression. It's our bread and butter. No matter what the cause, we can assess and treat depression. And if they struggle with it, and if they have difficulties, then there are specialists out there, but we need a few more of them. Often our patients are discharged because they don't turn up to appointments, they don't attend to the CMHT appointments or the crisis team, or they forget or they go to the wrong place, and are discharged after 2 no-shows. And sometimes these days, given waiting times, it's 1 no-show and you're discharged. But also there's this bias and discrimination still that comes along with having a mental illness diagnosis and also having a traumatic brain injury as well. I think whenever I was first starting out 30 years ago in brain injury rehab, I remember sort of one patient in particular saying, I should feel glad to be alive. I know my life was saved, but this is my life now, and I don't want to live a life like this. And it was really impactful because the whole family was so frustrated that this person didn't want to live anymore, having survived and having been brought back to life after a traumatic brain injury. So there's a real stigma about someone admitting that they don't want to live anymore after their lives have been saved. So just moving on to talk about suicide, because not only does depression carry morbidity with it, also there is a risk of mortality with depression. And sadly, following a brain injury, you're 2 to 3 times more likely to commit suicide than if you haven't had a brain injury. And again, staggering, just staggering. Up to a quarter of the people with a brain injury have thought about taking their own lives within the first year. And that's even higher for adolescents, so young people going through brain injury who, struggling with the change and the alteration in their role and what rehab brings to them, also having those thoughts about self-harm and about suicide. And the difference between brain injury and suicide risk, and maybe, for example, a diagnosis of having cancer or a terminal illness, is that it's lifelong. So if you have a diagnosis of cancer, your risk of suicide is highest at the start following your diagnosis, but with brain injury, that risk is persistent the whole way through every stage. There have been coroner's inquests about suicide and brain injury, but there's still a lot of unanswered questions about the whys and about the numbers as well. Some of the things that we do know, though, that is there's an association between having early mood symptoms following a brain injury and suicide risk, having lower educational attainment, having premorbid mental illness, and previous suicide attempts as well. So there's some of the red flags, but they're not enough because they're very vague red flags. The more severe the brain injury, the higher the risk. But also a group who are often missed are those who have the repeated mild traumatic brain injuries. And again, this group have already higher rates of suicide, self-harm and depression. And we should be sort of thinking more about what's happening with their brains if they're presenting to both mental health or also to our neurological services. So people who have experienced intimate partner violence, childhood trauma, so physical abuse, neglect, and also emotional abuse, because we know the brain develops differently if you've been emotionally abused as a child. People who are in contact sports, and I'm sure anyone in this room could think of a professional sports person who has had depression, who's been maybe high profile and in the news about their mood disorders, and what is the role of those repeated injuries, and would they ever admit that it was due to their sport? That's the other issue. And also we've got the huge topic that we could spend all of today and probably into the rest of next week talking about substance misuse, in particular alcohol misuse and the damage that can cause to the brain and the association with mood and suicide. So why? Like everything of what we do, and let's face it, this is why we work in neuro, isn't it? We're problem solvers, we're detectives, so it's complicated, isn't it? And another gorgeous slide. This has a bit of colour this time, I suppose. So whenever we're trying to work out the why, all of you in the room are great at formulation. I'm sure you are. You're used to rehab formulations. Psychiatrists less so. We used to be, and then it went away for a little while. It's coming back, you'll be pleased to know. But the biological, the psychological, and the social reasons, I've given examples of some of those there. And I just wanted to point out that there's been a national suicide prevention strategy that maybe some of you are aware of or you've heard about. It was published in September 23. There's an all-party parliamentary group about suicide prevention as well. And I read through the document and I was dismayed to see that they talk about the psychosocial causes of suicide and the psychosocial interventions for suicide, and they don't mention the biological. So that, excludes a whole part of opportunities for diagnosis, for assessment and intervention. We wrote to them, don't worry. So whenever we think about the biological, I'm just keep checking my time, and you're going to shout. Oh, that's great, Sarah. I like a shout. As you know, most brains that are injured are not naive brains. They've had a history, okay. So it's always really important to know the brain that has been injured, do some digging and find out what that brain was like. The severity of the injury can impact as well, and also the location of the injury. Hypoxic brain injuries, more likely to lead to depression, usually because there's more inflammation and more risk of damage to the limbic system. I put fatigue and apathy under biological because I think we all know, and I put it under psychological as well, because we know that about 10% of people who've had a brain injury suffer from apathy. And it can be difficult to tease apart apathy and depression, can't it? Sort of knowing which one, where's the chicken and the egg. And then that's when you have to sort of modify what your outcomes are going to look like for that person. But apathy is so common and is probably one of the leading causes of frustration in carers for supporting someone through their rehab journey. Does someone have epilepsy that's uncontrolled, or even controlled epilepsy and on medication for that could be bringing the mood down, making them feel drowsy, weak, not in control of their surroundings? Sensory impairment as well, we know can lead to depression. Pain. Now, you guys are probably really good about asking about pain, but psychiatrists are rubbish about asking about pain, really rubbish at it. But if you think how prevalent headaches are following a brain injury as well, and if anyone in the room has a headache at the minute, I'm really sorry, hopefully not contributing to it. But I know when I get a headache, you just want to go into a dark room, don't you? And you just want to stay away from the world. And if you're having constant headaches for years and years with no end in sight to that, the impact that can have on your mood. Substance use, of course, as well. And again, you'll see in that psychological column, these are a lot of executive functioning symptoms that we're seeing here. And I've got a young man that I look after. I work in a male-only service. If I refer to my young man, that's who I'm talking about. And, you know, he gets very easily frustrated, very classical frontal lobe syndrome, really super frustrated about everyday tasks that he can't do anymore. He used to be a great mechanic, and now he just can't do that. So he gets really frustrated. Problem-solving skills just aren't there, a very concrete way of thinking. And so he says, right, that's it, I'm just going to kill myself now. And he did. He went out and got into a car and drove into a wall. And so he gave himself a secondary brain injury. Had another man who had exactly the same set of symptoms, and he put a rope in the back of his car and tried to hang himself from a tree, and he got a secondary hypoxic brain injury 6 months after his first brain injury. So that sort of difficulties with judgment and decision making, not thinking of the consequences of action as well, can really increase those risks. And that could be one of the reasons why we see not just depression being increased, but suicide, completed suicide following a brain injury. And then the social impact. My goodness, where do we even start to untangle that? That change of role and function. And that seems to be particularly affecting men and young men. And women less so, but still so. That loss of relationships, we know divorce rates are high, homelessness, poverty is high amongst our traumatic brain injury group as well. And my patient group, who are the offenders, committing offences following a brain injury as well, and the impact that has on them, and getting caught for offences they maybe previously would have gotten away with as well, and ending up in prison and all the life changes that brings. I talked briefly about the role of pituitary damage, I think just focusing a little bit on the biological stuff, and also depression is a bit different. Whenever they look at the scans, and they've done research in this, they've seen that it's not just the serotonin pathways that are involved in brain injury depression, but also the dopamine pathways seem to be involved. And dopamine is part of our reward centre, so we're not getting the same feedback from things that would have ordinarily given us pleasure. And there's more research being done into this, and really interesting stuff on inflammation. And the reason why it's interesting is because this could lead to potentially preventive strategies being put in place. If you knew that somebody had a 50 to 60% chance of getting a particular type of infection following a brain injury, but if you treated it in the first week after a brain injury, I think we would pretty much treat it so long as that treatment didn't cause harm. So, that's the hope, is that something that is fundamentally a symptom of brain injury, depression. Are there things that we could do that could treat that early with maybe even simple strategies like an anti-inflammatory? We're still waiting for that, right? And the prime brain we talk about as well, that non-naive brain. Even people with schizophrenia are twice as likely to have a brain injury. So that brain that already potentially has structural or inflammatory changes going on due to the schizophrenia, has been on medication and the changes there, then has a brain injury on top of that. If I can be indulged for a few minutes to talk about my population, and just spend a few minutes talking about suicide in prisons. I'm not sure if anyone here works in the criminal justice system, but I know that it's an area that has been highlighted recently in the neuro rehab teams about how do people with brain injuries in prisons get the help that they need in a safe and an effective way. In other words, how do they get the same treatment as everybody else who has a brain injury? So we've been doing some work with the Acquired Brain Injury Justice Network, and my colleague Hope Kent, who's a researcher there, and she's been looking at suicide rates in prisons that are all very well published, and to see if there's any link between suicide and brain injury, because that's kind of the way to get the government's attention. If we can find something, an intervention that could reduce suicide rates in prison, then we're more likely to get some help and support with that. So really common that 24% of all deaths in custody are due to suicide, and the rates are between 3 and 8 times that of the general population. Horrifically, for women, 10 times the rate of suicide in women's prisons. And the first 7 days are the highest risk. Self-harm in prisons, very similar rates as well. Again, women's prisons, prolific, absolutely prolific self-harm. And it's estimated that, and these are from government statistics, that 10% of prisoners are currently receiving mental health support, but 70% need them. Yeah. And we also know that with our population who have cognitive impairment or a brain injury in prison, they are the least likely to seek help for their mental health in prison. And at the minute, the way things work, if you're not picked up on screening whenever you're first brought into reception in prison, then it's sort of self-referral. They have keypads now for self-referral to mental health teams if you need counselling or support. Our patient group aren't going to do that or access that. And so I have quite a few under my care who have gone into crisis whenever they've been arrested, their brain injury hasn't been picked up, and they have self-harmed very seriously and sustained further injuries or just become increasingly distressed. And where do they end up? Segregation. And now segregation, although it's a horrific place, whenever someone goes into segregation, they have daily reviews, and part of that is a mental health review. So whenever I'm talking to prison staff, I ask them to use those opportunities to ask about brain injury. If they could just ask about brain injury during what's called an ACT review. So Hope looked at HMP Park, and they use the Do It Profiler, which is an amazing screening tool, screens for absolutely everything. And what they found in HMP Park is that there was a 12% reported history of suicidality and 11% of self-harm, and 9% reported traumatic brain injury. And whenever Hope sort of put this together and looked at it, if you had historic brain injury, you had 3.3 times the risk of suicide in prison. And that is compared to substance use that was 1.9. And that's very different from what I was taught as a psychiatrist growing up, is that substance use would put you at the highest risk of completing suicide. But on this particular population, it was having a historic brain injury. So what do we do about it? I sort of want to end on a little bit of hopefulness. I think the first thing for all of us is asking about depression, asking about mood, asking about thoughts of self-harm. There used to be this feeling that, oh, I can't ask somebody whether or not they harm themselves or whether or not they thought about taking their own lives because maybe that'll get them thinking about it. Maybe I'll sow a seed in their minds about this is what they should do. The opposite is true, and it's been well researched. It can actually be an opening up of an opportunity for that person to talk about things that they've kept inside, and also to understand some of the emotions they're going through and normalising some of those feelings as well. And what an opportunity for family members and relief as well, for them to have the chance to talk about what they've seen, trying to understand that too. There are screening tools that are available to use, and they have been validated in the brain injury population. I'm sure you've all heard of the PHQ-9, is what GPs commonly use. It's not brilliant, but it gets the conversation going. And it has been used in research, and over time as well, it can help. Sort of having a number can help to see if your interventions are helping, if you see improvements in the PHQ score. And there's also the Beck's Depression Inventory. I think the psychologists and other therapists in the room might be used to using that. And there are suicide questionnaires as well. And you can see probably from my tone of voice, I'm not a great fan of things like that. I think because sometimes it can overcomplicate what can be quite a simple question and compassionate conversation, but they can be useful in terms of measuring outcomes and also research as well. Risk assessments likewise. I'm sure you all are up to here with risk assessment tools. But look, in the simplest form, they are, what are the chances here? What's the worst case scenario here? And what could we do to maybe bring those chances down? And who do we need to involve in order to contain those risks better? And that leads to then your crisis plan. Informing and educating. I'm sure, if you've been in contact with hospitals, I've spent a lot of time over the past 4 months in and out of hospitals, but just having someone give you a diagnosis, a name, tell you what is going on or what's likely to be going on, can really bring anxiety levels down and can really help in terms of instilling some hopefulness. So don't be afraid to diagnose depression in your group. Also, there are some really, really good websites. There are really good resources available for people who have depression and brain injury, and particularly for carers as well. And we're thinking in particular Headway have some fantastic online resources, as do BrainKind, the former Disabilities Trust. I can't get used to calling them that though. And that sort of collaborative approach as well of involving the carers, involving the loved ones, obviously with the consent of the person who's been affected. And then understanding, going back to the why. So no one intervention, no single intervention is going to cure depression following a brain injury. It can't. It can't. And I think in psychiatry we've been guilty over the years of what's the tablet for it? What medication are we going to give for this? Well, this is a case where we have to have a holistic and a formulation approach. And I know this looks nasty, but I actually love this, because this is how my team works. You just need to go through each of the bits of the person's life and their brain that can be affected by the brain injury. Have a think about what their symptoms are, what they're presenting with, what they're telling you, and where then are the opportunities for intervention. So if it comes to physical health, what are the blood sugars doing? Is the person's diabetes stable? What about their epilepsy? Is it well treated? Could they be on a newer medication for epilepsy that maybe is less cognitively impairing? What's the pain like? What's the temperature regulation like? With the cognitive difficulties, are they using the compensatory aids to give them a feeling more of independence, of independent living? With the emotional needs, does there need to be some support in place for that person? Have they become lonely as a result of their brain injury? And then that pre-injury as well. What was the brain like before it was injured? And is that an opportunity maybe to pick up on things like, has there been domestic violence? Was there a history of childhood trauma or neglect that maybe needs exploring as well and looking at, using those opportunities for interventions? And then, don't be afraid of treatments. The treatment for depression, as I said at the start, it's the same whether or not you have a brain injury, but you adapt that treatment. So using what you know about that person's cognitive impairment to adapt the therapies that you use in those interventions. So CBT, dialectical behavioural therapy, schema therapy are all used in my service, even though we were told years ago, oh, you could never use dialectical, though they've got cognitive impairment. No, if you adapt and, psychologists in the room are well used to adapting whenever they're delivering these treatments, and other therapists as well. But just having that awareness of what the cognitive impairment is and then adjusting your outcomes and your therapy accordingly. Individual is better than groups, generally speaking, particularly in the early stages, due to concentration, attention difficulties, etc. But also defining the goals. So what we find in managing depression in our service is that it's often a functional goal rather than a mood goal. So sometimes, due to the difficulties with the dopamine system, etc., there may be still that pervasive feeling of low mood, but actually the function has improved. And they're better able to function cognitively, better able to get on with daily tasks. And oftentimes in rehab, that can be, a really great outcome actually. Someone's functioning better, but just not being able to get that feedback about how they're feeling, particularly whenever someone is talking about feelings in the longer term. Medication, I'm going to really go through very quickly. Start low, go slow. It's what I say to all my trainees. So just being aware that our patient group are much more prone to having side effects from medication. Just starting with a lower dose, it always gives you the opportunity to increase doses, and be really mindful of interactions with anti-epileptic medications as well. First-line meds are selective serotonin reuptake inhibitors, sertraline or fluoxetine, you maybe have heard of most commonly. And seek advice, particularly whenever it comes to switching and withdrawing antidepressant medication as well. There is a risky time in terms of side effects and suicide increase during withdrawal. So just being cautious and asking advice. And some medications are also fatal in overdose, so being cautious with those if there is, someone who's expressing sort of suicidal intent or there's a history of that. Final slide. I'm in time, it's great. The future then, so as sort of been alluding to, we're still working out what's going on with depression and brain injury. We have the stats now that tell us it's super common, but the holy grail, I think, of medicine is about prediction and prevention and early intervention, isn't it? And I'm hoping that we're getting closer, at least for some of that biological bit, to be looking at sort of those earlier interventions, being able to predict who may develop depression later on. And that will hopefully lead to treatments. Deep brain stimulation, whole day, we could talk about that. And also the role of artificial intelligence and guided self-help. We're just starting to see that. And actually, some of the systems that are being used are really quite good, just for that fairly early sort of help and intervention, sort of highlighting issues with mood, and then looking at very practical steps as well. So I think MindKind is maybe one of them. Looking again at those at-risk groups who may have fallen under the radar, but who have those repeated mild traumatic brain injuries as well. Super interesting group, really high risks of developing depression, suicide. But I suppose my take-home message, like I said at the very start, is having the conversation. Please just ask. Just ask about depression and ask about suicidal ideation. Dolly's my guru. I know I'm the image of her. But I just love this, and she's great for phrases and sayings, isn't she? It's like, we can't direct the wind, can we? The brain injuries happened. We can't direct the wind, but we can adjust the sails, or we can support someone in adjusting their own sails and maybe changing the course that they're heading. So thank you for your time.
Thank you. That was really interesting, and we're really glad that you come out of hiding for us today. Has anyone got any questions for Czarina? Have we got a mic somewhere? There's somebody there.
Thank you. Thank you very much. I was just wondering, you mentioned that depression tends to be higher in people with lower education after a TBI. I wondered whether that's also linked to the actual general cognitive functioning, because by logic, I would think that someone who were used to being very high functioning and all of a sudden find themselves being very low functioning due to a brain injury would have a harder fall compared to someone else.
Absolutely. So I think generally speaking, the lower educational function is linked with every mental illness. Every single mental illness, one of the risk factors, poverty, lower socioeconomic status, lower educational attainment, have a link with mental illness. So I think that's why it's represented with the brain injury population as well. The higher fall, I'm not sure about that, because in my mind, that's kind of what, what you would sort of feel is that the change in function has been so drastic, so acute. And I really don't want to generalise, but in the population that I work with, the families are just like this mountain of support, generally speaking. And it is really very much a generalisation. But being able to access support as well seems to come easier to that population who might be higher functioning in the first place. I think also the role of why has that person got low educational attainment is important. So has there been the abuse, neglect? Has there been, sort of congenital problems or whatever that have affected their propensity to develop depression too? So, yeah, it's not straightforward or linear, is it? But generally, my experience has been that the higher educational attainment just cope a little bit better due to the support network that's around them.
Okay, sorry, very quickly, when you mentioned fluoxetine and the fact that people with TBI may experience higher side effects, how about nutrition? If we think of fluoxetine and the reduced appetite that comes with it as a side effect, is that something that you see?
Yeah, so when starting any antidepressant, always look at the lovely charts that have the side effect profiles and see what matches your patient. So generally speaking, sertraline is my first go-to because it's got relatively good side effect profile, relatively well tolerated. Fluoxetine I find a little bit agitating, but that can actually be quite good for someone where maybe apathy is a presentation that's sort of lifting things quite big, but then you have the trade-off with the appetite as well. So it is a bit of a balancing act. But starting low, as I say, low dose, those side effects usually will emerge really quite quickly, and stunningly so actually, compared to my general adult colleagues who can use very high doses very quickly. I've never been able to do that in my population at all. But yeah, get out the chart that has that side effect comparison and hopefully be able to guide your choices.
Thank you.
Is there any more questions?
Hi, that was really interesting. Thanks for that. So I'm just going to talk about opening the conversations. I manage lots of community teams, and when, especially HPs, OTs, physios, and when they're out there, it's more when they come across somebody who expresses suicidal thoughts that we're recognising that's more and more.
Yeah.
And so we've started with the psychologists doing some training for them around, Friday afternoon, and you go and see your patient and then they express that, because I think it's quite frightening and you're worried, like, are you going to say the wrong thing? What do you say? So we are looking at that. I think it's, quite a challenge, but a training need for therapists around that.
Yeah, absolutely. And actually, Headway were in contact with me, because Headway are sort of there in the neurotrauma units, aren't they? Sort of after someone's had a brain injury, and exactly that. It's always a Friday afternoon, always. And the psychiatrists seem to be clocking off earlier and earlier on Fridays. Sorry if there's any other psychiatrists in the room. I think I'm okay to be like that. It's my own profession. But I think that's absolutely brilliant. The training is essential. I think we need to be doing more as a college in supporting the training of AHPs and other health professionals in that sort of very crisis, urgent management.
And at home, because quite often we're in patients' home, they're on their own with somebody. It's different when you're in a neuro rehab unit or on a ward, but when you're on your own, it's quite a scary thing.
Absolutely, sort of leaving that person with a... crossing your fingers is never a great strategy, is it? Whenever we're doing this job. So yeah, having that sort of who to contact and when to contact them is really important. And obviously if someone has cognitive impairment, their ability to do that on their own, and then getting consent from them to share that information with a loved one as well. I think, we do underestimate how complex this is, don't we, as well? And I think our mental health colleagues maybe underestimate how complicated it is working with our population. But great that you have psychology coming on. That's really fab.
That's been the key thing, and
Yeah.
they've done a little pathway and, supporting clinicians with that.
Yeah, that's brilliant.
Any more questions anywhere? Okay. All right. Well, thank you very much, Czarina. That was really interesting. Thank you.